Discovery, and the shuttle has cleared the tower.
Ready? What's going on, you guys? Hey, welcome back to the Health or High Water podcast. Oh my gosh, we are so sorry. It has been, 6 weeks, I feel like, since we've
12.
been on a hiatus. But we are in season 3 now, so welcome back. We have an awesome episode. We got Trip, of course, producing over there. What's going on, Trip?
How's it going, man? Good. How about you?
I am doing fantastic. And Elizabeth Goldberg, Dr. Elizabeth Goldberg, thank you so much. Your schedule's so busy. Thank you for taking time out of your day. I appreciate it.
I'm delighted to be here.
Okay, so correct me. I'm going to dive in. So correct me. I just want to go over just a little bit about what you've done and where you're at right now. You're at Anschutz. So you're a practicing emergency room physician. You have a specialty in falls, and you work a lot with the geriatric population. You went to, you were a Brown University graduate?
That's correct.
Okay. Before we go any further with that, are you from Colorado? Where were you born?
I was born in Ohio, in
Okay.
Dayton, Ohio, but we moved to Berlin, Germany when I was 18 months old, and I went to high school there and then came back to Ohio for college.
Okay. How did you end up at Brown? Like, were you just like straight A student out of high school?
I was matched at Brown, so when you're a physician, you're told where you get to do your training. There's this fancy algorithm called the match, and I interviewed there. I loved it. They loved me, and so the algorithm matched us, and we ended up in Providence, Rhode Island, which is a great town.
Okay. Was that always like when getting into medicine and stuff? That's kind of it's a dream I think a lot of people have because you get an opportunity to work with populations and I think make a huge impact. Was that just something as a kid, like when you started out, you knew you wanted to do, or just kind of as you got into high school and did well? How did that come into fruition?
It's crazy. I don't have anyone in my family that's in medicine, but when I was 13, I had a good friend and her mom was a nurse and she let me use her stethoscope. And from that point on, I was in love. I was like, I need to do this. Whatever happens, I'm going to be a physician. So very lucky that it worked out for me.
That's interesting. That was the moment?
That was the moment.
You could visualize it? That is so interesting. As a kid, how old were you when that happened?
I was 13.
Okay. You
Yeah.
had a stethoscope on. You're like, hey, I could actually do this.
That's right.
Just start with stethoscope with the dog and everything. Yeah.
It was definitely plastic and cheap, and it probably didn't work, but it was enough. It was enough to interest me.
And many years later, and you've had published articles that you've had in the Journal of American Medical Association. You've had funding. You've run research articles on your own. You've done tests, which is super interesting. I wanted to ask about the technology piece of it. You did one, I believe it was possibly in 2020, where you were researching whether tablet exercises could reduce falls for seniors. Could you talk a little bit about like how you set that up and kind of what your findings were in that?
Yeah, so we've done a lot of work on falls prevention. We see a lot of patients that come to the emergency department for a fall, and I always felt that the way that we treated them wasn't the best way that they could be treated. There was a lot of variation in care, and anytime there's variation in care, you think, is there just not enough evidence base? And there wasn't. And so what we did is we brought physical therapists and pharmacists into the emergency department to see those patients that had come in with a fall. And right now we're using the Apple Watch 2 and the iPhone to do kind of digital tests of cognition and function because we notice that folks that come in with falls, they often have some cognitive problems. It can be the first sign of a cognitive problem like dementia, or they have they're on medications that cause sedation, and that increases their risk for falls. And then in the function kind of arena, we know that folks that fall often have lower extremity weakness or balance issues. So what if we can assess them with these digital tests? We don't need staff members to do it. And then based on that, we can personalize intervention. So that's what we do. That's our gap care intervention, which is the intervention we came up with.
When you said you came up with it, is it like... So then would you say it's like a proprietary sort of screening process, like you assessed it and you're like, hey, here's ways we can improve it?
Yeah, I'm not sure about proprietary. It's open to everybody. Yeah. So I'm an academician, so usually don't get proprietary interventions. Yeah. So basically what we realized is in talking to our case managers in the emergency department, they said we really need more PTs in the ED. And back when I started this in 2015, there weren't physical therapists that we worked with in the emergency department. We just really, it was all emergency clinician led. And now we're seeing so many more physical therapists in the emergency department. And so we just basically came up with this plan. I had a good friend at the time that was a geriatric trained physical therapist. And I said, what do you think we need to do for these older people that come in for falls? And by the way, it needs to happen in 20 minutes. We don't have a lot of time in the emergency department. We want to get people in and out. And we were able to put together a really fast and efficient screening that basically helped us identify, okay, this older person, they need community fall prevention exercise programs, or this particular older person's really weak. They really need home physical therapy. They're homebound. They need someone to come to their house to get them started with these exercises. And so based on kind of those discussions, we got some funding from the National Institute of Health, and we were able to rigorously test it in a clinical trial. And we found that patients that went through our program were 66% less likely to come back to the emergency department for a fall. So that was significant. That was real exciting, and that kind of launched my research career.
Interesting. You mentioned like a lot of them come in. They have like cognitive. That's like a pretty right away? You're screening for that.
Well, that's what I'd like to happen. So I did some additional training after my emergency medicine residency in geriatrics and aging. And so that's kind of my niche within emergency medicine, is to improve care for older adults. So one of the things we're really pushing heavy now is let's do screening for dementia and delirium and other cognitive problems in the emergency department, because a lot of patients go to their primary care doctor and they don't mention their, memory lapses and those problems that are happening. But we see it really obviously in the emergency department because they're there for a fall, or they're there for some other terrible thing that has happened to them. And it's a kind of a teachable moment and important opportunity for screening. So if we can start it in the emergency department, we set them on a whole different path, because there's a lot of things you can do to prevent full-blown dementia, but you can't treat it. Once you have dementia, it's incurable. There's nothing that can be done. There's some medications now that might make the symptoms be better, but we don't have a cure.
Yeah. There is a screening process for dementia pretty straightforward?
There's lots of different, there's lots of different tests, and what I get excited about is some of the digital screening tests now, where patients can screen themselves and they can get an assessment themselves of what their memory problems are. There's a screener we like to use a lot. It's called the 88. You basically ask the caregiver that's there, have you observed changes in their memory? Have you observed that they used to be able to do this but can't do this now? It's a really quick test. It doesn't take very long. So we can do it if we are concerned about it.
How accurate? Decently accurate?
Yeah, it's decently accurate. Yeah. It's a screening test, so the point is you screen them. If they fail, they score low, then they have to go on to a more comprehensive screening, like the MOCA test, or usually what we do then is we refer them for neuropsych testing or screening through a neurologist, because those screening tests are really long. We can't do those in the emergency department. It takes too long.
Yeah, and you were saying like you might only have 20 minutes, so you're trying to, you're saying that because because we have patients coming in? Is that sort of the idea, like, hey, we need to be prepared for the next person coming in? Exactly.
So an emergency department works best if you see patients within 2 to 4 hours. They don't have a longer length of stay than that, because when there's people that wait in the waiting room, that's when heart attacks, strokes, that type of thing happens in the waiting room before they're seen by a doctor. And so we really care about efficiency, not just because those patients, like older adults, they get confused if they stay in the healthcare setting for too long. So it's good for the patient that you're seeing at that moment, but it's also good for the patients in the waiting room that have serious conditions and aren't being evaluated.
That's a super good point. Let me ask you kind of, if you don't mind, an adjacent question. So you've been through obviously a ton of schooling, a lot of internships, and then you've had your practice for so long. You've done all these things. Is there anybody that you can think of a person that was a mentor to you that stands out as like, I learned the most from this person, either a mentor or an experience? So you're like, hey, I learned the most from having this as an experience. Maybe it was a class. Is there anything that sticks out to you that you're like, this is how I learned the most?
Yeah, I've had so many mentors through my life and sponsors through my life. One person that is probably well known to a lot of listeners is Esther Chu. She's an incredible emergency physician. She's at Oregon Health Sciences University, and she used to work at Brown. She was my faculty mentor, and she is just the person that can summarize what's happening in the healthcare setting and disseminate it to the public. She's on CNN a lot.
Okay.
And a lot of physicians are not that good about communicating their science or meeting with the public or other people and really breaking it down in a way that matters to people. And she's just excellent at that. And she's also a mom with 4 kids. I have 4 kids. So seeing someone that was a little more senior to me do that and do that successfully was a huge inspiration.
Yeah. Mentorship is the most valuable thing in this industry. Like, we can't be successful. I think that's why I asked that question. Without people that we see who we can visualize and go, wow, if they're doing it, then I think I have a chance to be able to do it too. I didn't know you were a mom of 4 kids, so okay. So now that adds a whole other. That leads me right into my next question, and this is kind of coming from me. So, and Tripp and I are busy ourselves running. 7 or 8 different senior communities. We're balancing the gym, personal training clients, playing music, all these other things. Relaying that to what you're doing and all the stuff you have going on, what's the best way you're managing your time? You did mention before the podcast that you're doing 90% research now.
That's right.
Are you also mentoring other physicians, other members in that? And you mentioned the interviews too. How are you managing all the time? How do you do it? Are there certain days dedicated to this?
I am, always busy, but so is everybody. It's really about what you prioritize in your life. So first of all, I have a really helpful partner who really manages our home life, helps me take care of 4 kids. I think having equal partnership in the child rearing and home activities is so critical. It's the only reason why I've been able to do all the things I do. I also have worked with our emergency medicine scheduler to come up with a clinical schedule that works. So I work the Saturday overnight. No one wants to work a Saturday overnight shift, but because I work that, it gives me a little bit more predictability in my schedule, and then I can be there Saturday days and Sunday days for the kids when they play their sports and other activities. So that's real important to me. And then I have a team. I have a whole lab that asks what they need to do, and I give them tasks, and they help me get it done.
You make it sound pretty black and white. The follow-up question to that is like the collaboration. When you're working with a team, especially as you are with people with different skill sets and egos and emotions and their personal life, what's the secret for you for being a leader, not just a leader, but a female leader in the community and such an important piece? What's your secret to being a good leader and being a good collaborator?
Yeah, collaboration's so important. So I think 2 big things: execution, so the things that you commit to, actually following through with those, and being a go-to person that solves problems has always served me well. That's a skill set that I think a lot of emergency physicians have, because we're often kind of the last step in a patient's journey where they're like, I'm frustrated, I couldn't get into my primary care doctor, I can't solve this problem, I've been waiting forever to get this MRI or the neurologist. So we solve problems, we solve social problems. So I try to be a problem solver. And then in terms of collaboration, so a lot of the work I do is with other professionals. So I rely a lot on my pharmacists. I rely on my physical therapists that work with me. I have some very close geriatrician friends. I have a social worker friend that helps me kind of design these digital interventions. We have a whole lab dedicated to geron technology, which is this sort of new field of tech for older adults. And we meet on a regular basis, and we move these projects forward that are important to our patients. So, yeah, collaboration is really key.
That's huge. Yeah, you mentioned tech. What's going on in the tech space with gerontology, and you can either discuss it from like a falls perspective or just from a perspective in general, from your position, kind of like the oversight that you have right now with your position. What's coming out in tech that you're excited about or that you think will make a big impact in this industry?
Yeah, so 10 years ago, if you had an older loved one, let's say your grandma, and she was at risk for falling, she had to wear this sort of pendulum thing around her neck, fall alert systems, and it was really stigmatizing. People don't like to show others that they're at risk for falling. Now we have all of these cool devices that can detect falls and actually call 911. So I do some work with Apple.
Nice.
I'm not funded by Apple, so I have no conflicts of interest, but I think it's really great when they came out with a watch that you could, give a watch that looked kind of inauspicious, looked cool, and give that to mom. And then if she fell and she passed out, instead of lying on the floor for 3 days, the paramedics would arrive and bring her to the hospital, because that's a big thing we see in the emergency department. People who live alone, they're older, they don't have caregivers, no one checks in on them, and then they end up on the floor, and you can imagine they have muscle breakdown, then they get very, very ill. A lot of those patients end up in the intensive care unit. So fall alerts have come a long way. They're kind of integrated with these consumer-based technologies now, like smartwatches. I love that. The other thing that is really growing is these assisted technologies for folks that want to live independently at home. So we're seeing more and more people that are coming to our hospitals and they just have no way to get assistance from a caregiver. There's less caregivers for every older person. It used to be 7 caregivers for every older person. Now it's 3 caregivers for every older person. So it's really important for us to equip them with the technologies that they need to stay at home safely. So those are monitoring technologies. Those are alerting technologies. Some are kind of attached to the top of a wall in a room. Some are on your wrist. So that field is really growing, and I'm excited about it because most people want to live at home. They don't want to be in a nursing facility.
For sure.
And they want to stay as independent as long as they can. So
Yeah.
we need to assist them with that. I think that field's really growing.
Yeah. The tech has exploded, hasn't it? In every field now, in general.
100%. We were talking before about using quantitative science as the future of health and wellness. I would even say just preventive health in general. And speaking on that, obviously no one wants their loved one to go to the ER ever. Are there some things that you're finding out? It's kind of a 2-part question. One is commonalities in falls, like surfaces, staircases, muscle atrophy. What are some commonalities you're finding, and as well as what are some ways we can prevent loved ones from actually ever having to go to the hospital, God forbid?
Yeah. So the majority of falls are actually in the home. And one of the kind of key things to do is to make the home safe so you're not falling. I mean, pets, you can't really prevent them from getting ahead of you. Pets are a common reason. But those carpets that aren't really fastened to the floor, having a lot of clutter in your house. What happens as we get older, our peripheral vision goes. And then we can't really see the type of things that we would have avoided in the future. Doing a home safety evaluation. Sometimes there's nurses that can come out to your house to do that, or even just going through a checklist. The CDC has a website called Steady. They have a checklist for things that you should do in your home to make it safer. Having grab bars in the bathroom, all those things are really important. And then some falls happen after people drink alcohol, when people are started on new medications, so antidepressants, blood pressure medication, pain medication, sleep medication, all of those tend to have a sedating effect. And when your brain is already aging and then you add a sedative, that is just a recipe for disaster. But there's a lot we can do, and actually every older person that has Medicare can get a free assessment of their medications to change those meds to reduce their risk for falling. I really recommend that. It's a really important step. We have an epidemic of too much medication use in the United States. Physicians, and we're kind of part of the problem. We like to start medications and we don't stop them very well. So for your listeners, if you're on medications that make you sleepy, that's a good reason to talk to someone and see if there's other alternatives, or maybe you can stop those.
Yeah, that's a super good point. How did you get into when you became an emergency room physician? Did you just kind of naturally start working with the older population, or was that a choice where you're like, hey, I want this? How did that happen?
Yeah, I went through emergency medicine residency training like every other physician that wants to be an ER doctor. And then at some point I realized, the older folks that come to us, they are getting treated the way that an 18-year-old would get treated in the emergency department. And they have totally different physiology. They have more medical problems. They're on more medications, and they really need a tailored approach. And then I started a postdoc fellowship, a research fellowship in aging, and my eyes were just open to all the things that we could do to make our care better in the emergency department. And from then on, I've become such an advocate for improving how we dose medications, improving how we care for older folks that come into the emergency department, keeping them hydrated, trying to reduce their tethers. So one of the things we do is we like to put fall alarms on folks and then Foley catheters in, and all of those tethers can make older people more confused. And so I think there's been a lot of changes. There's this really growing field of geriatric emergency medicine. More and more people are saying, it's important that we treat older people differently. So I'm excited about the emergency rooms of the future, where we get this right.
Yes.
Well, speaking on that, like, you obviously got a team. You're kind of the forefront here of this niche medicine. What are you teaching the next generation of physicians coming forward? Like, what are the most important things you're teaching them, and what can we look forward to with this new style of thinking?
Yeah, so I train residents. Part of my role as an academic physician is to work with residents that are in training to become great emergency doctors. I'm really lucky to work with the Denver Health residents, and they know when they come on shift, Dr. Goldberg's working, we're going to learn a lot about aging and geriatrics today. And so we have a lot of discussions about, so normally you would just admit this person to the hospital, but let's talk about the risks of admitting someone that's older, and let's lay out that risk to the patient and let them make the decision with us on, would you rather go home with these resources and, physical therapist showing up tomorrow and rehab at home, or do you want to stay in a bed over the weekend where you might not move at all, and we might put you on medications that you're not used to, and you might get confused. So we have a lot of conversations about what's the right setting to treat older folks, and there's definitely this push to get people at home, get them the care they need at home instead of doing it in institutions. And then we have a lot of discussion about the medications that are safe, how you treat pain differently in older people, how you recognize if someone is confused and what you can do to reduce that confusion, and how you involve caregivers in care. So it's right now, there's not really a standard approach to getting family involved, but we know if you're 90 and you have dementia and we give you some paperwork and send you home and we don't communicate with your family, it's not going to go well.
Oh my gosh.
That was going to be my follow-up question. It's like, okay, someone comes in, they got dementia, and you're like, well, you got dementia. Like, do you treat them even if they say no, even though they need it? Like, well, what's like the ethical thing to do with that too as well? It's like so hard.
Yeah.
Hard thing to make, because like they're so confused.
Right. So capacity really comes to play here. And in the past, if we questioned whether the patient was making good decisions for themselves, we would get a psychiatrist involved, and they would come and kind of decide on the ethics of not providing care or providing care. Right. But now we actually do the capacity assessments on our own, and we ask them a series of questions that sort of elicits from them, like, how much do you understand about the risks? If you don't want this heart attack medication, do you understand that part of your heart may die, that your myocardium is going to die, and then you might get heart failure, and this is irreversible. So you have to really discuss with that patient and kind of inquire how much they're understanding. And many older people that have dementia, they're a little embarrassed that they don't remember, and so they act like they know and that there's no concerns, and they minimize because they just don't want to be hospitalized, or they just don't want that treatment. And so we try in those cases to identify who the healthcare proxy is, who can speak for them, and then we have to decide if they have capacity. They're allowed to refuse. Anybody's allowed to refuse care if they understand what the consequences are for them.
Sure.
And so those are really important questions that also come up that folks in geriatrics are especially trained to do.
Yeah, I mean, we do that with that in our own side, as far as, do you understand, if you don't, ours is a little less like cleaning up your diet, like your goal, you're never going to hit your goals as long as you understand. You know, I told you earlier we work with a lot of seniors and memory care units, several different memory care units. And some of the classes are as big as, 40, and some of them are as small as like 6. But what we see a lot of times is like there's a whole different spectrum of capacity with older people. Some of them just like to be there and smile and have fun.
That's great.
And they don't want to totally participate. And they get nervous if you are too. So. And then some are there and they're just, so we teach boxing. So some are there and they're just like, we have a 102-year-old in one of our classes and a couple that are 100 and they're just, going to town, smashing it. So I think, yeah, that's the big thing is like understanding that there's a different capacity with people and in the industry, just being good about starting to recognize and go, okay, this person doesn't like this, so I have to make sure I don't make them feel uncomfortable.
Right.
Asking them questions that I clearly know that they can't hear, process, and then try to speak.
Right, and those folks, first of all, I love that you're doing that. It's so important to stay active, and you can be active at any age.
Yeah.
And those people that are sitting there not seemingly participating, I bet they're getting something out of that social setting.
Oh, totally.
We have a total epidemic of loneliness
Yes.
and social disconnectedness, and them sitting there and being around other folks, that's important to health and well-being too.
Yes. Well, the company, we work for a couple different ones, but one that I'm referring to, Ascent Living Communities, does one of the finest jobs instilling the right people, like the most passionate people. The classes and services they offer are incredible. They're always incorporating music. There are always activities when we come in. The atmosphere is just great. So when you walk into those, you're like, okay, somebody's doing it right. So that's one thing I really love to see.
There's been great research on music and dementia, and it's just a wonderful way to keep people happy, and sometimes it helps them remember good times. And there's actually really good research that shows that music is helpful for those populations of people with dementia.
Yeah.
Well, I was telling Brad on the way back from class, my mom's got dementia. And I was trying to play guitar for her and sing for her, and she like put her hand on my guitar and was like, "Let's let the radio do it."
See, they can be very clear about their preferences. Like, they might not remember what they did 5 hours ago, but we know that folks with dementia, they can still be very clear about what they want.
They're
and
so
you're
funny.
wise to listen to her.
They are so funny too. The jokes they tell are just on point.
Well, there's no filter, and I kind of love that. I know we're getting towards the end here. You're on a time schedule. We just want to thank you so much for coming on. If there's anything you want to plug here, that research that's going on that you want people to find, please let them know. I'll attach it into the copy of the podcast. But if there's anything you want to shout out.
Yeah, so if you are worried at all about falls risk, there's so many great resources. We have resources at Anschutz. We actually have a new chatbot that helps people find resources in their area called Livy. Cool. So you can Google Livy and UC Health. And then exercise. It's a lifelong thing. I love that you're doing this.
Yes, you hear that? You're hearing it from the best. You must exercise twice a week. Trip says 3 times a week. I say twice. It doesn't matter.
Should be 4, but
yeah, whatever. Just get out and move your body. You guys, thanks. Sorry for the long break. Thank you so much for you coming on. Appreciate you.
Thanks for having me.
Let's do it again. Let's stay in touch. Thanks to the listeners. We've been chatting with Dr. Elizabeth Goldberg. You can find all of her stuff in the description below. You'll see it. And if you have any questions, we can relay it to you, and we'll stay in touch with you. And, hope you have an amazing rest of your day.
Thanks so much. Love being here.
Yeah, thanks to the listeners. Thanks, Trip, for producing. And we'll see you guys on the next episode. Peace out.
Ricky.